Community participation. This aspect of the IMAM program seeks to engage in dialogue and collaboration with members of a given community. It actively involves the community health workers who serve them, and their health facilities in managing acute malnutrition. This aspect involves early case detection and referral at the community level through an outreach program, ensures high coverage and early management of acute malnutrition. This leads to good clinical outcomes and reduced strain on inpatient facilities. Community participation has two main elements. 1. Active case finding for early detection and referral. 2. Follow-up of problem cases in the community. There are 4 steps which will be explained to help to achieve those 2 elements. The first step is to conduct a community assessment to understand the organization of the community, how undernutrition is viewed in the community, how the new service will be received, and how it will be supported by the community. It will highlight the limits of the healthcare workers' knowledge of that particular community and will identify potential barriers or facilitating factors in uptake of IMAM services. The key questions to answer during a community assessment are: 1. What is likely to affect the demand for IMAM locally? And 2. How can community outreach be organized to meet this demand most effectively? The second step is to formulate a community outreach strategy, a process which is done at different levels of the health system. At national level, we develop the community guidelines for the implementation of IMAM services, advocacy, coordination, and mobilization of resources, plan and organize task force meetings, and review policy guidelines. At provincial level, we adapt visual aids and flyers, disseminate the IMAM messages using the appropriate media, monitor consumption patterns and stock status of RUTF, RUSF, F100, F75, CMV, and Risomal. Review IMAM admissions and overall program performance. At district level, active screening should be under the direction of the district nutritionist, who is the focal person. The community nursing, health promotion, environmental health, and the health information departments should be involved to ensure coordination so that the various outreaches do not compete with each other or overburden the village health workers. The training of trainers on active screening and nutrition education of the outreach workers and or volunteers should be delivered at district level to all the nurses. District nutritionist ensures that supplies of RUTF, RUSF, vitamin A, zinc, iron, as well as folate are available in the health facilities, and alert the provincial nutritionist or pharmacist when stocks are low so that supplies can be replenished on time. Plan the organization of the community mobilization to facilitate coordination at district level with district health team. The district health promotion officer and the district nutritionist can be in charge of community mobilization within the district health team. The frequency of the active screening should be coordinated by the DNO and the district nutritionist or HPO. The screening data should be collected at district level under the guidance of the district nutritionist, DHIO, to determine 1. The degree and the change in nutritional status in the district, and 2. The validity of the data collected. Active screening for severe acute malnutrition should also be organized in conjunction with vitamin A supplementation campaigns, the expanded program of immunization, EPI days, and coordinated with other community-based activities. A. At health center level. The nurse in charge of the health center or OTP is usually responsible for coordination and monitoring of the village health workers' activities once a month, training the village health workers to conduct active screening using MUAC tapes, and examination for bilateral edema, follow-up of defaulters, and integrating these activities with other community-based activities such as EPI, OI, ART, etc. B. Outreach activities. For the villages that are more than 5 kilometers or 2 hours walk from the OTP site, compliance with the treatment is much less than for villages close to the OTP, the catchment area. These villages must be screened and have a village health worker taught to screen children. Active screening for severe acute malnutrition should also be organized in conjunction with vitamin A supplementation campaigns, HIV counseling and testing, HCT, pediatric ART, PMTCT, antenatal clinics, and EPI days. Depending upon the accessibility and numbers of children with SAM in remote villages, there should be scheduled visits weekly by a trained focal person from the OTP, for example by motorbike, provision of a mobile team, or opening of a new SFP site. SFP sites can be organized much closer within the villages. At community level, we will engage village health workers, VHWs. These are volunteers selected by the community and living within the community. They liaise with the local health center, who oversees their activities and supports them. They sensitize the community about the IM services before and during its implementation. They perform the screening, MUAC, follow-up, referral, and other outreach activities. Visit the village or group of villages close together periodically within the catchment area of an OTP. Visit villages where there appears to be a problem, such as excessive defaulting, low rate of weight gain, etc., or when requested during a monthly meeting, or when the community nurse comes in rotation to help with the OTP and recruit volunteers. Check with the village heads to maintain their involvement in the program and to provide feedback about the program. Follow up the defaulters to determine reasons for defaulting and assist in seeking health services. Maintain a strong link between the health center or OTP, village leaders, and other community-based health workers. The third step is the development of materials and messages to be communicated to the community. Messages to be disseminated to the community may include burden of acute malnutrition in Zimbabwe and the particular district, consequences of untreated acute malnutrition such as infections, stunted growth, post-school performance, and death, information on services available and where to access the IMAM services. Posters and flyers with information should be made available to the community, especially at areas where communities gather. Other relevant materials can also be used to disseminate information. And the final step is the program rollout, where the community is mobilized and trained. Here the village health workers need to be trained to mobilize their communities and perform case finding. They are trained to detect acute malnutrition in the community through the use of MUAC and identifying edema. Active screening of children less than 5 years of age is aimed at identifying children with severe acute malnutrition and moderate acute malnutrition and referring them to the nearest health facility. The village health worker will measure MUAC of children 6 to 59 months of age, check for edema in all children in the 0 to 59 months age group, refer to the health center all children identified as having severe acute malnutrition or moderate acute malnutrition or identified during the community-based growth monitoring for further assessment. The village health worker keeps a register of under 5s in the catchment area and monitors them on a monthly basis. Caregivers of children who are growing normally are encouraged to continue good health and nutrition practices. Active screening should be integrated within the community IMNCI and can be conducted during campaigns such as immunizations, deworming, vitamin A supplementation, and growth monitoring. It can also be conducted through home visits. Active case findings presents many advantages. Number one, patients are identified and treated before they develop complications. 2, treatment can be achieved entirely in the community. 3, prevention of admission into inpatient facilities. 4, this has important implications on cost of transport, loss of earning ability, family disruption, failure to complete essential work, reduction in the level of care for other children, and increase the capacity to reach all that require treatment. Village health workers will also conduct follow-up visits where necessary. Follow-up of clients is done to ensure compliance and to assess response to treatment. Link up clients with community health workers, conduct home visits using the appropriate checklists, ensure that clients referred to different interventions are complying, and give feedback to the health facilities. Village health workers conduct home visits on a regular basis. Home visits focus on households where children or adults are not recovering, have deteriorating medical conditions, are not responding to the treatment and should be admitted for inpatient care, are not presenting for follow-up visits at the health facility, need constant monitoring of new practices taught during nutrition counseling sessions. It's sometimes easier during a home visit to gently inquire the reasons why a patient has defaulted or is showing poor response. It is also an opportunity to encourage a patient to return to treatment or to provide support to the caregivers to ensure recovery. Home visits are done with a standard checklist that will ensure that key areas of follow-up are covered. It is important to be in constant communication with the community. The community must be sensitized in an ongoing process, and regular means of maintaining contact with the community should be established. Community members, by attending meetings, can regularly voice their views and suggest alternative courses of action. The ongoing sensitizations include such things as the community's perspective of the interventions, which may include identifying new barriers to access, and joint solutions to problems, limiting the impact of the interventions. This promotes community ownership of program development and implementation. To ensure the component of community participation is implemented effectively, other key players will have roles to play. At district level, we have the district nutritionist, who has to monitor overall program management, mentor and support the health facility, ensure that all tools for management of severe acute malnutrition, see the annexes, are available at the health facility, do regular on-job training when necessary, collect monthly reports and compile them, and ensure that supplies of RUTF, IUSF, vitamin A, zinc, iron, folate are available in the health facility. Alert the provincial nutritionist when stocks are low so that supplies can be replenished on time, and ensure coordination with the district. At facility level, we have the health facility nurse, who will be responsible for stock management of IMAM supplies and making quarterly orders through ZAPS. Triage and manage all cases referred to the health center for management of severe acute malnutrition, referring to the stabilization centers when it is necessary. Training the village health workers in active screening using mid-upper arm circumference, NUAC tapes, and examination for bilateral edema. Follow-up of defaulters and integrating these activities with other community-based activities such as the Expanded Program for Immunization, EPI, and Community Integrated Management of Childhood Illnesses, IMNCI. Meet with the village health workers monthly to collect the community information and address any difficulties that arise. Sensitize the community about the IMAM services before and during implementation. Visit villages where there appears to be a problem, such as excessive defaulting, low rates of weight gain, or investigation of failure to respond to treatment. Inform community leaders, other members of civil society, and local organizations about the nature and purpose of the IMAM services and the nature of their involvement. The health facility will also conduct passive screening where each child, as well as adolescents and adults with a thin appearance, are screened for malnutrition, and if present, they are managed accordingly.